Hi, my name is Tariq Adar, and today we're going to talk about the clinical basic science aspects of electrophysiology. We'll throw in a couple of clinical correlates. We're not going to go too crazy into electrophys. The purpose of this lecture is to sort of set up a branching point so that when I later do a lecture on muscular electrophysiology, this will be present. When I later do a lecture on cardiac electrophysiology, this will be present. And when I do nervous system, which is really the big organ system that I have planned next, this will be available for you to loop back to. So Coulomb's law states that charges exert electric forces on each other, and these electric forces sort of participate in an electric field. All right, and for the purpose of physiology, the electric potential difference across the membrane is what we're most concerned with, because the distance across the membrane doesn't change too much. So when we're dealing in electrophysiology, we kind of make some assumptions that the lipid bilayer isn't changing while we make our calculations, etc. And ultimately, this phrase gets reduced down to the electric field, depends mostly on of potassium, is minus 58.1 millivolts to log base 10 of the potassium inside versus the potassium outside the cell. And you don't have to memorize this, but we'll circle back to it. So as you can see here, outside of the cell, the ion sort of sits in this extracellular space. It's positively charged, and water is a polar molecule where the oxygen is negative, because remember oxygen sits like this, has its two electrons here, and has its two hydrogen bonds, and oxygen pulls on the particles more than hydrogen does, and that leads to electronegativity. And that electronegativity lets it sort of hydrate these cations. So they're just sort of hanging out over here, and you have this channel, right? So you have a water-filled single filling region, and you have this channel, and it'll have to change shape in order for this cation to get through. And on the other side, you have the cytosol. So you have ions on this side and ions on that side. So as you can see, the electrochemical gradient is dependent on a couple things. It's going to be permeable to potassium, chloride, and sodium. It generates, the movement of these generate electric current, calcium to some extent as well. And we're going to assume the permeability to chloride is negligible, though that's not 100% true. Chloride does have channels, and the exchange of chloride is very important, but for what we're talking about here, we're going to disregard chloride. So what determines the permeability? The ion channels. Whether they're open or closed determines whether the membrane is permeable to those ions, all right? And that's very important, and we'll talk about why towards the end of the lecture. So potassium is what mainly determines the resting potential, because that's the channel that tends to be, there's a leak channel that kind of sets it, but we'll talk about that in a bit. So I want you to pay attention to the potential and the terms inside it. You have a constant, a logarithm, base 10, and potassium and sodium. All right. When we look at a logarithm, we see the base 10. What that means is that log base 10 of 10 is equal to 1. All right. So as a number becomes less than 10 inside the logarithm, as this expression becomes less than the number 10, you get further and further less than the number 1, and that's what leads to a negative logarithm. So for example, if you take logarithm of 0.01, that's the same as 10 to the negative 2. So that's log base 10 of 10 to the negative 2, and that's equal to negative 2. So you went from 1, so the further you get away from 10 in a logarithm function, the more less than 10 you go, the more negative you become. All right? So that's something to keep in mind. All right, and it's going to make more sense when we see it on the other slide. So for example, let's say for potassium, if we start to increase the potassium outside the cell, what's that going to do? It's going to increase the numerator. And as this numerator increases, it's always going to be less than 10, right? This whole term is always going to be less than 10. It's always going to be negative. But as the numerator increases, the number is going to become less negative. All right, because the number inside this whole thing is going to become closer to 10. The number inside this whole expression is going to get closer to 10 if you increase the potassium. Likewise, if you decrease the potassium outside the cell in states like hypokalemia, what's going to happen is that because this term in the numerator is going to become less, you're going to get even less than 10, and you're going to become even more negative, right? Okay, and we'll kind of review that as we see other examples on the next slides. So you have skeletal muscles, neurons, and cardiac cells resting in the range of -60 to -90 millivolts, and we'll see what determines that. And it's the transient increase in the permeability of sodium and calcium channels that allow the Nernst equation to be modified. So normally calcium and sodium are not going to participate because there's no permeability of the membrane. There's nothing for them to pass through. So they can't really generate a potential because they can't pass through it to begin with. Now, when channels open, so when sodium and calcium channels transiently open, the default state is closed. They open for a little bit transiently, and when they open, that leads to depolarization because now all of a sudden they can participate in the Nernst potential. And remember, there's a lot of sodium outside the cell as opposed to the inside of the cell. So if you remember on the last slide, there was like an Na out over Na in. This number is going to be much higher. So the whole logarithm of this number here is going to be much larger than 10. All right, this whole expression is going to be much larger than 10. So the whole logarithm is going to become a more positive number. And that's sort of what contributes to how the depolarization happens, but we'll go over that. All right, so let's review real quick how logarithm works mathematically one more time. So you have log of a over b. Logarithm base 10 of a number less than 1 is always negative. 0.01 is the same as 10 to negative 2, and the log of 0.01 is negative 2. 10 to the power 1 is 10, so the log of 10 is 1. So you can see that anytime there's an expression less than 10, if what's inside the logarithm is less than 10, the number is going to become smaller than 1. All right. So let's compare the potassium outside and inside the cell. The potassium outside is usually a tiny amount in the range of 3.5 to 5, and the amount inside the cell typically contains 140 to 150 millimoles per liter. So you do 5 over 150, it's going to be about like what 5 over 150 is the same as 1 over 30 or something like that, right? Let's do the math real quick. So you do 5 over 150. 5 becomes 1, 15 divided by 5 is 3, so 30. Yeah, it becomes 1 over 30. So clearly this is a value much less than 10. It's going to be a negative number. And as the number in the numerator is, so let's talk about hyperkalemia. If this number in the numerator gets larger, so if this gets larger, the number in the logarithm is going to get larger. And as the number in the logarithm gets larger, the less negative this overall expression is going to become. And in hypokalemia, the opposite happens. As potassium decreases outside of the cell, because remember, look at the relative amounts. There's barely any potassium outside the cell and a decent amount inside the cell. So small changes in a small number like 3.5 or 5 is considerable. The sodium outside the cell can be it's kind of the opposite. The sodium outside the cell is about 140. So small changes in sodium don't really produce a large magnitude of neurologic deficits, right? Or physiologic deficits, because it's a very large number. So small changes in sodium won't make a big difference. You would need a much larger change in sodium concentration to facilitate enough of a change that the sodium change actually contributes to the Nernst potential, a meaningful change in the Nernst potential. Whereas in potassium, because it's already so small outside the cell to begin with, very minute changes in potassium can have catastrophic effects. Like if you go from 3.5 to 2.8, that is a dangerously potassium. That's a dangerously low potassium, and it can cause problems. And I've had a patient who died that way. So when we go ahead and we look at the expression, again, hyperkalemia, the number outside becomes larger. This whole expression becomes larger, gets close. Whatever's in here is getting closer to 10, and it's going to be less of a negative number. And as we look over here, in hypokalemia, if we come back over here, if the potassium outside the cell is decreasing, then what's going to happen? The whole expression gets smaller, and what happens as a result of that? If the whole expression gets smaller, it's becoming further from 10. The whole thing inside here is becoming less than 10, more less than 10 than it was before, and you get an increasingly negative resting membrane potential. And we'll see that on the next slide. So some stuff that can cause hyperkalemia, just rapid fire for you to keep in mind. Hyperkalemia, potassium sparing diuretics like amiloride, certain conditions that inhibit the ENaC channels. Hypoaldosteronism can cause that. It's also a type of renal tubular acidosis. These things can cause hyperkalemia, and there's other things as well. Those are just a couple off the top of my head. And things that cause hypokalemia, I mean, one of the most important ones you need to know are diuretics, particularly thiazide diuretics. All right. Um, but I don't want you to focus too much on that. I'm just trying to show you how there's a couple things clinically that cause these conditions and these electrolyte imbalances. Diarrhea, vomiting. These also affect your electrolytes as well. And you're going to have a lot of patients who have nausea, vomiting, diarrhea. So the reason why electrophysiology is so important is because it's linked to electrolytes, and electrolytes determine a lot of the disease state. All right, and there's a lot of conditions that affect electrolyte balance, and a lot of internal medicine is managing electrolytes. So that's why I'm trying to really focus on this, kind of have people understand what's going on when we talk about, oh, their potassium is low. Okay, potassium's low. What does that mean? Are we treating a number? No, we're not treating a number. When we say someone has low potassium, dangerously low potassium, what we're actually saying is that this potassium has fallen so low that the potential that's being generated by potassium has become more negative. And because it's more negative, the cell cannot fire action potentials required for the proper physiologic functioning of the heart and of the muscle and of the brain. And this has consequences, lethal consequences. All right? That's what we're treating when we treat hypokalemia. It's not just the number we're treating. Okay. So as we move on over here, we see that this is a normal physiological potassium, 4.2, and inside the cell is about 140. This is pretty standard. Physiologically, now in the case of hypokalemia, let's say you're around a relatively dangerous low potassium level of 2.9. You can see here that increases the potential, the electrochemical gradient, so it becomes even more negative. There's even more incentive for this movement. And as you see with the hyperkalemic state at like 5.5, which is mild hyperkalemia, as you can see here, the difference, the incentive, the electrochemical gradient has decreased. All right, because 142.9 is a bigger difference than 140 to 4.2. And 140 to 5.5 is a smaller difference than 140 to 4.2. All right, and you see the narrowing and widening of the electrochemical gradients correspond. So hypokalemia increases the gradient and hyperkalemia decreases the gradient. And when we do the math, you can see with normally you have 4.2 and then negative 93 here. But as you increase this to 5.5, so as you make the numerator larger and the whole expression inside the logarithm becomes larger, you become a less negative number. And you can see how that relates to the threshold required to fire an action potential. So hyperkalemia makes it easier to reach the threshold, whereas in hypokalemia, the number in the numerator decreases. And because the number in the numerator decreases, what's going to happen is that this term is going to become more negative, and because it's more negative, it's even further away. The resting membrane potential moves from this normal value of negative 93 for potassium, it comes all the way down to negative 103. All right, so you have increased difficulty firing an action potential. And what this is showing here, so this alpha, remember the way it was written, you had your 61.5 plus et cetera, but inside the logarithm, you had potassium out, and potassium in, but then you had this term alpha, which I don't want you to stress out about right now. It's not particularly important. Sodium in, but know that when channels are closed, this alpha is irrelevant. It's basically zero. So when alpha is closed, the membrane potential only really kind of directly corresponds to potassium, right? So as you see the potassium concentration here, the membrane potential here, and it's a straight line passing through the origin. All right. As opposed to when alpha is a non-zero number, you can see that this resting potential, not this resting potential, I guess you could call it a resting potential, but the cell membrane potential becomes exaggeratedly positive. All right, so you can see it sort of comes back to around here. And alpha of 0.03 is sort of what normally physiologically in humans where we rest at. And so why does it become more positive? Well, that's because sodium is allowed to exert its effect. If alpha is 0, then what you're saying is that this doesn't exist. But physiologically, it's more of an alpha of 0.03. All right, and you can see that sodium's effect, because remember, sodium is usually in serum sodium, you can have like 140 and then a smaller number than that inside. And because the number outside is so large, it's a positive. What's the expression inside the logarithm is positive. It makes the expression inside the logarithm more positive, right? And that reflects with the membrane potential becoming more positive, which sort of hints at the role of sodium channels in the action potential. So going back to what really determines the resting membrane potential, so the potential of sodium is a positive 61, as we predicted earlier, and the resting potential for potassium is about 93. So why is the resting potential still negative? Why is it negative 65 to negative 70? What balances this out so heavily in favor of potassium? Well, the thing is, sodium does leak. While sodium can leak through the membrane, it has to leak through the lipid bilayer, which isn't very efficient. Additionally, there's a sodium-potassium pump, which is going to, whatever does leak is going to get yeeted back outside, and what can leak over here from potassium comes back in. But what sort of offsets all of these things is the fact that potassium has its own leak channels. There are explicit leak channels, and it's explicitly the leak channels that allow the functioning of this pump so that whatever leaks into the sodium gets yeeted back out. And these channels and these leak channels allow permeability of the membrane to potassium. So that's what allows potassium to determine the resting potential. So negative 93, when you sum up all the effects, it's more negative 65 to negative 70, but still very much in the favor of potassium. So hyperkalemia is going to increase the resting membrane potential closer to the threshold, and hypokalemia is going to drop the resting membrane potential to a more hyperpolarized baseline. All right, so it's harder to reach the threshold from here. So in hypokalemia, you have less excitability. Hyperkalemia, you have more excitability, and both can lead to arrhythmias, but for different reasons. All right, so let's talk about hyperkalemia specifically first. If hyperkalemia increases excitability, you're going to have more excitable pacemaker cells, and that's going to lead to arrhythmia. And you're going to have muscle weakness due to inability to repolarize, because you're going to have decreases, even though you have decreases in the refractory period, so initially. So at first, because you're closer to the threshold, it's going to make it easier for you to fire. But remember, you have to fall back below the threshold to fire another action potential. You have to fall back below the threshold to fire another action potential. If you can't repolarize because of hyperkalemia, your refractory period is going to become longer. All right? And so while hyperkalemia will decrease the refractory period initially, what it's going to do is potassium will actually bind to its own channel and increase its conductance, and that prolongs the refractory period on top of all that. All right? So as hyperkalemia, so there's sort of like a spectrum. As hyperkalemia worsens, first you get, synchronous repolarization, and that leads to peak T waves. You get broad and then absent P waves, a widened QRS, and the severe end of hyperkalemia will be asystole and heart block. Why? Because the lack of conduction is what allows aberrant electrical currents to generate an arrhythmia. So there's two things going on. You can either have an absence of conduction, and that's just going to cause heart block and lack of contraction. Additionally, you can get arrhythmias, tachycardic arrhythmias, because what will happen is if the pace isn't being set by, so the SA node isn't very affected by potassium, but the AV node is. And if the AV node isn't really conducting potentials, what will happen is that you'll have these focal points of conductivity that come from the heart muscle itself, or the Purkinje fibers, bundle of His, and that can be problematic because you'll end up having these action potentials that are firing but not within the proper conduction system, and they'll sort of cycle and cause this arrhythmia, this fast heartbeat, like a ventricle. And it's a non-effective heartbeat, so it's potentially lethal, like VFib or VTAC, or just flat out asystole if nothing is being conducted. Now, I don't want you to really memorize all of that. The point of this lecture isn't even to talk about hyperkalemia and its effects on ECGs. And if you've never read an ECG, what I just said was mumbo jumbo. What I'm trying to have you understand, the big point here, is that hyperkalemia increases the threshold, and that increase not increases the threshold, it increases the resting membrane potential closer to the threshold. And as you get closer to the threshold, you're more easily to excite, but it's also more it's difficult to come back into a repolarization, because you do depolarize, but then you have to repolarize. If you can't repolarize, you have problems. Now, hypokalemia causes less excitability, so the T wave flattens. The QT, that the QT sort of tells you for the time between when when the ventricles have contracted and when the ventricles have relaxed. So hypokalemia causes less excitability, and that causes everything to take a lot longer to conduct and to contract, and that makes you more susceptible to, prolonging the QT makes you susceptible to ventricular tachycardia. So it's sort of the same fundamental idea that if you don't have a very steady pace being set by the two pacemakers, the SA and the AV node, that's what makes you susceptible to arrhythmias. All right. And there'll be a different lecture about the cardiac, manifestations of hypo and hyperkalemia in terms of the electrophysiology. But for now, all I want you to know, that hyperkalemia brings the resting membrane potential closer to the threshold, making it more excitable and less able to relax and repolarize, whereas hypokalemia makes it more difficult to depolarize, period. All right, so the potassium determines the chemical gradient. A change in the outside compartment, the extracellular fluid compartment of potassium, that changes the potential, as we've described earlier with the Nernst equation. And a change in the resting membrane potential leads to a change in the excitability of a cell. So that's sort of the whole gestalt of it. Why do we care about electrolytes? Because electrolytes directly affect the excitability of cells. So these are just a couple of channels and their disease states that cause mutations. You have the KCN channels that cause long QT. There's a lot of different, channelopathies. We're not going to go into each one. You have renal outer medullary potassium, Bartter syndrome. So this sort of prevents potassium from being lost in the urine. Brugada syndrome, which has a couple of channels that are involved in it. And leads to sort of a short QT and predisposes you to atrial fibrillation. You have the sodium channels, SCN channels, which really predisposes you to a bunch of stuff. Epilepsy, paralytic conditions. There's one sodium channel deficiency. I think it's like NAV 1.7. You don't feel pain at all. Cystic fibrosis, transductance regulator, aka ATP binding cassette C7. That's the chloride selective channel. Ryanodine receptors, those are intracellular cation channels found in muscle, and they're associated, mutations in these are associated with malignant hyperthermia, anesthesia-associated malignant hyperthermia. And severe combined immunodeficiency, there's the ORI channel, and it's important in the function of the maturing of the lymphocyte, and defects in this channel can cause immunodeficiency because lymphocytes don't function. So I'm not telling you these because I think you need to know them right now. Only a couple of these are testable on exams. I mean, you do need to know like Brugada syndrome. You do need to know long QT, but you don't need to know the exact channel. You just want to know that changes in potassium channels cause long QT. Mutations in potassium channels cause long QT. Mutations in some channels are going to cause Brugada syndrome, and that's related to, atrial fibrillation, increased predisposition to AFib, paroxysmal AFib in particular. And then you have CFTRs, cystic fibrosis. This is a very important mutation. I'm going to have a whole lecture dedicated just to cystic fibrosis. All right. So here you have the ryanodine receptor. Oh, this is important as well. So yeah, that's the last one I kind of want to emphasize. These ones are testable, and commonly testable, but the only real channels you actually have to memorize are probably going to be these two here. CFTR for cystic fibrosis and the ryanodine receptor. for malignant hyperthermia. All right, and then we come over here. So as you can see, you have different channels, and each one is very, very selective for a specific ion. You have potassium, sodium, chloride, and calcium channels. All right, and you can see sort of the two membrane layers form plates. So remember how things work in an electric circuit. You have your positive end plate, your negative end plate. Um, and you kind of have the distance between them, and that generates an electric field. And and the properties in between the two plates is what causes variation. It's the dielectric constant. So the lipid membrane has that same configuration. You can think of it as two charged plates with ions on either side, charged particles on either side, right? And then you have other channels like gap junctions. So you don't necessarily just need to have channels on either side of a cell. Even between cells, you can have gap junctions. Right? So these are the connexons, and one reason why these connexons are important, these gap junctions, they're made up of two different connexon proteins, and there's a couple of things that are important, like in the heart, it's a proper functioning of gap junctions that allow all the heart muscles to beat at the same time, because allows ions to flow through. Once one cell has an influx of ions, all the cells connected to it by the connexons also have that influx. All right, so you get this very quick chain reaction that goes off, which is important for things like heartbeat. Now, it's also important for things like nerve signals traveling through myelin. So in Charcot-Marie-Tooth disease, these connexons are mutated. It's CX32, and that mutation prevents the diffusion of signaling through the myelin. Remember, saltatory conduction, myelin speeds up signaling. And there's other connexons involved with other diseases. All right, but really, this is what I'm trying to illustrate for you. All right. So the nicotinic receptor is important. And I'm kind of bringing it up here. I'll talk more about it in more detail in a different, lecture. But the N1 nicotinic receptors are at the neuromuscular junction. You can block those curari. And N2 receptors are found in the autonomic nervous system on the postsynaptic of the postganglionic sympathetics. And if you don't know what that is, don't worry about it. And it's also found on the postsynaptic membrane of parasympathetic neurons. All right? So both types of receptors are activated by acetylcholine, and that leads to rapid depolarization due to the influx of sodium. All right? So think about that. If you want to put someone in, if you're doing surgery on someone and you don't want their body moving during the surgery, you're going to have to antagonize the N1 nicotinic receptors. And you're going to have to use an acetylcholine antagonist that's going to mainly address the N1 receptor. All right, and over here we just have an action potential. So you have your resting potential like we talked about, and then you depolarize for some permeate. So the sodium channel. So it's the sodium channels that generate the rapid initial depolarization. So going back, why I brought up the nicotinic receptor. So you go back to the nicotinic receptor. It's voltage gated, right? Acetylcholine binds to it, and when acetylcholine binds to it, this opens up, and that allows sodium to come through. Now this alpha has increased. All right, remember the alpha we talked about earlier? It's now increased, and I don't know if alpha increases per se. That's probably not the best way to put it. The better way to put it is that the permeability of the membrane to sodium has increased. So sodium is now permeable, and because sodium is permeable, what's going to happen? Remember, the potential of it is positive. It's going to make the resting membrane potential more positive. So it's going to come up, and it's going to hit. And if enough sodium comes in, you hit your threshold and you have your action potential. You fire, all right? You depolarize enough to fire through the threshold, and it peaks, and then it plateaus, and then it comes back down, all right? On this plateau, there's delayed sodium and calcium channels that contribute to the plateau, but don't worry about that right now. So you go up, you overshoot, and then you come back down, all right? And then you hyperpolarize and then repolarize. All right, so you depolarize, pass the threshold, fire an action potential, you plateau, you come down, you hyperpolarize, then you repolarize. All right. So there's an absolute refractory period and a relative refractory period. The relative refractory period, so notice, until you dip back below the resting potential, you absolutely cannot fire an action potential, right? It's really not until you get closer to the resting membrane potential, so sort of at this threshold right here, that you can fire if you have a strong enough stimulus. But when you're still all the way up here, you haven't repolarized enough to be able to fire another action potential. So that's sort of what the absolute and relative refractory period means. The absolute just means you're not even close enough to the relative, you haven't even gone down past the original threshold. How are you going to fire, you know? And as you can see here, sort of, it's kind of interesting because you see this shape and you come here and you can kind of see what contributes to it. At first, the membrane isn't conductive to potassium, but what does have conductance? Sodium. And who kind of comes in line with this peaking? Sodium. So you see the sodium conductance aligns with the depolarization, and the increase. So you have this delay before the potassium conductance increases, and then this potassium conductance increases, and then you can see the membrane potential come back down. All right. In the meantime, the sodium conductance comes back down to 0. All right. So the sodium channels open. You fire the action potential, then they close. In the meantime, while this process is occurring, the potassium channels have opened, and now this conductance is what's causing repolarization. All right. Now, calcium has effects on sodium channel open probability. We're not going to talk about why. It's so beyond the scope. But what I'm trying to show you is that note that at this point, where the resting membrane potential is, and note that when you increase calcium, the potential becomes more positive. As you decrease calcium, the potential becomes more negative. So as calcium decreases, the open probability of sodium increases, all right, at lower voltages. That's extremely important. I think you might have missed it, so let me say it again. So look here at minus 50. Let's see. Okay, so let's see. Here's the best way to do it. Let's start with a probability and work our way from there. Let's say, all right, there's a 20% chance that the sodium channel will open and cause depolarization. All right, at a calcium of 2, that happens at resting potentials in this area here. At a calcium of 0.5, that's going to happen around here. So you can fire at a more negative potential. Does that make sense? Think about it. It does make sense, but think about it. All right, ask yourself, does this make sense? And so try to work through it with me one more time. At any given probability, all right, at any given probability, we can see here that 2 millimoles and 0.5 millimoles have the same probability. However, in the hypocalcemic state, when there's less calcium, you can fire at a more negative point. That probability is the same at a more negative point. Whereas in hypercalcemia, so as you increase calcium, what's going to happen? As you increase calcium, you can fire at a more positive point, all right, or at a less negative point. So the less your calcium is, the more likely the sodium channels are to open, all right, at any given voltage. All right, at any given voltage, the lower the amount of calcium, there's an increased probability of sodium firing. All right. So as calcium decreases, the open probability of sodium channels increase. The sodium channels are able to open at lower voltages. So hypoparathyroidism, hyperparathyroidism, these are metabolic disorders that cause neuromuscular deficits by altering plasma calcium levels. In hypoparathyroidism, you're going to have things on the spectrum of fatigue, depression, etc. And in hyperparathyroidism, so let's not worry about the clinical manifestations. I might have had those mixed up for a second. In the hypoparathyroidism, the bigger thing I want to point out is that you're going to have less calcium. In hyperparathyroidism, you're going to have more calcium in the serum, assuming it's primary hypoparathyroidism and primary hyperparathyroidism. If none of that made sense to you, don't worry about it. You might not have taken endocrine yet. Your big takeaway from this slide the massive takeaway is that as calcium levels decrease, because they interfere with sodium channels. So as calcium levels decrease, that interference decreases, and because that interference decreases, what's going to happen is that the sodium can fire at lower and lower membrane potentials, all right, which makes it more excitable, the whole cell more excitable. And here we have cocaine, Sigmund Freud's favorite drug, and these act on those sodium channels and prevent depolarization, right? Lidocaine, procaine, tetracaine, and they're used topically to treat pain, and they can be used for arrhythmias. Now, what's neat about these is that they are most effective on the axons that fire repeatedly. So they're selective. They specifically interfere with sodium channels that are trying to fire frequently, which is great if you're treating an arrhythmia, and there's different types of arrhythmias, but one type of arrhythmia results from an overactive firing of sodium. All right, so what you can do to address that is use lidocaine or procaine, lidocaine, and by using lidocaine, you can block the arrhythmia by selectively preventing that one action potential that's been firing, and also makes it useful for pain because pain involves rapid firing. So that's why we use them topically. That's why we use them for arrhythmias. All right, so this is just illustrating the use dependence of inhibition by lidocaine. So the inhibition is, so notice here when the axon fired like once, not the axon, when the cell fired an action potential like once, it didn't, these dots represent inhibition events. All right, the amount of times it was inhibited. If it's like if there's a rate of 1 per second of stimuli, there's not a lot of inhibition. But as you go to 2 to 4 to 8, the inhibition is increasing. All right, so lidocaine is an anti-sodium channel pharmacologic that we can use to treat pain, and we can treat arrhythmias because it specifically targets potentials that are being fired with increasing frequency. All right, and that's about it.